Hello, this is Ron Broussard, and today we'll be talking about Chapter 18, Altered Mental Status, Stroke, and Headache. But what we'll be covering is altered mental status and the many causes there of that. Now, there could be a very wide range of alteration in cognition and function. We could have a patient who is completely unresponsive versus we can have a patient who is alert but just a little bit confused. And now, a big concern with alteration of mental status is going to be the risk for airway compromise. And managing our ABCs is a very vital part of managing patients with altered mental status. A big thing with strokes and stroke care is recognizing the onset of symptoms and getting the patient to the most appropriate facility. Now, with headaches, headache in and of itself isn't so much a condition as it is a symptom of an underlying issue. So we should never just dismiss a headache as like, oh, well, this is just a headache, it's not an emergency, blah, blah, blah. We should really look at this as a symptom that could be something that is very seriously happening to the patient. So we're going to talk about a few things that we need to look at when assessing our patients and when dealing with alteration of mental status and some of the symptoms that patients get. So alteration of mental status is a dysfunction of the reticular activating system or cerebral hemispheres which interfere with consciousness. So if you remember back to your A&P and pathophysiology, in order to be conscious, you need at least the reticular activating system and one hemisphere of the brain to be functioning. If both hemispheres aren't working, but the reticular activating system is, which that system is just a bundle of nerves that transmits messages, you're going to have an unconscious state. Or if both hemispheres of the brain are working, but the reticular activating system isn't working, you're still going to have an unconscious state. So in order to be conscious, you need the reticular activating system to be functioning and at least one cerebral hemisphere. Now, with altered mental status, you do need to recognize this as a significant illness or injury. Now, there are many different causes of altered mental status, and we kind of branch these into two separate categories, one being structural and the other being more of a toxic or metabolic type cause. Now, with your structural causes, I want you to think of things that actually mess with the structure of the brain, like a brain tumor, a bleed, trauma, or direct tissue damage to the brain, or an abscess. Whereas your toxic metabolic causes, that's going to be issues, say, with oxygenation. So you have a patient that's hypoxic, or a patient that is diabetic and is having problems with glucose or blood sugar, where it's too high, too low. Kidney or liver dysfunction, where the body's not able to adequately filter out toxins. Okay, those are going to be more toxic metabolic causes for alteration in mental status. Now, other causes of AMS, things like shock or hypoperfusion, drugs. Now, with drugs that depress the central nervous system, that's where we're looking at our narcotics, like our opiates and opioids. Um, Patients who are post-seizure state or in the postictal state of a seizure, think with seizures, they're having this electrical firestorm that's going off in the brain. Well, when a patient's in the postictal state, their body is attempting to recover from that seizure, and they can be very lethargic. They can be exhausted, and they could have alteration of mental status there. Now, infection, we're kind of dialing back into our structural causes, like if it's affecting the brain, and then cardiac rhythm disturbances, if we're not able to adequately pump blood to the brain, and then of course a stroke, where we're not getting adequate blood flow to certain areas of the brain. Now, neurological deficit. Now, all a neurological deficit is any dysfunction within the nervous system. Okay, paralysis is a neurological deficit. Okay, so anything that's happening within the nervous system that's not functioning appropriately is considered a neurodeficit. Now, a neurological deficit is an indication of a problem that's affecting the central nervous system. And what we're talking about specifically here is dealing with stroke. So with stroke, some of the neurological deficits that we see are like, hemiparesis, where the patient's, like paralyzed or extremely weak on one side of their body. They may have speech issues where they're slurring their words, or they can't, generate words in general. Like they're completely aphasic, where they just can't say anything. I've had, a family member that had a stroke, and while they were going through it, they're they wanted to say something. They just, for whatever reason, couldn't produce the words to say it, and they were very aware that they couldn't produce those words. So, with acute stroke, time is a critical factor in stroke management. One of the biggest things that we want to know in the hospital is going to be the onset of symptoms. Onset of symptoms is very important in how we then treat these patients. Time is critical. So, with this, that patient needs to be delivered to the hospital within 2 hours of the onset of symptoms. Okay, and then receive intervention within 3 hours of the onset of symptoms. We have that little extra hour of leeway there for us in the hospital to be able to, do an assessment, get the patient into CT quickly, to do a scan to determine is it a bleed or is it a block, and then provide appropriate treatment. But that's why EMS is so important. And asking those questions. Hey, when was the last known well time? We call it last known well time, because now if it's less than, this onset of symptoms happened an hour ago, you guys are going code 3 to the hospital, giving a report to the hospital quickly, in order for us to prepare for that patient, so we can get them to CT quickly and then provide adequate care. Time's so important. Okay. Now, the American Heart Association and American Stroke Association developed the mnemonic FAST to quickly recognize possible stroke. FAST stands for facial droop, arm drift, speech, and then, of course, time to get that patient to appropriate care, or time to call 911. We'll talk about the FAST mnemonic a little bit later, and how we utilize that within our stroke skills. So again, time is a critical factor. Now, understand that you guys as EMTs make a significant difference, okay? Just by finding out, the patient may not be able to talk, okay? But ask family, when was the last time they were seen normal? Okay, last known well time is so important to getting these patients to adequate care. So when was the last time they were seen normal? Because that makes a difference with transporting. We're either going to be going code 3 if I have a patient that's within that window, emergent lights and sirens transport, versus a patient that, had a stroke. Last known well time was yesterday, and the family didn't think anything of it, but they just weren't getting better. Now, 8 to 12 hours later, we can't do anything to really help that patient. We can, but it's going to be extremely limited because the damage has already been done. So, last known well time, very important. Now, with the pathophysiology of stroke, now talking here about cerebral circulation and ischemic penumbra. Now, just like with the heart, our body is amazing in the fact that if we have a slow onset of, say, occlusion in a vessel, what our body begins to do is it starts to develop this, collateral circulation, where you'll have small blood vessels that'll be created by the body in order to get blood flow to areas of the body that don't have that adequate blood flow. Like high cholesterol, if we're like packing our vessels full of, gunk in a sense, and we're having reduced blood flow, our body slowly can start to develop this collateral circulation. Now, with these patients that are having this, when they have this, stroke that occurs or this blockage that occurs, ischemic scales, those cells become electrically silent until circulation is restored. So those patients have like a pretty good outcome because those collateral vessels are able to get some blood to that area. Now, that area of silent cells, that is the ischemic penumbra. Now, with those patients, okay, this doesn't necessarily apply to ones where there is a sudden blockage, like a patient who has atrial fibrillation that develops a clot, in their heart, and then that quickly moves up to their brain, and now you have this sudden onset of altered mental status because of a very acute blockage. All right, the body doesn't have time to develop collateral circulation. So just understand that some patients can have a very positive outcome and have a complete resolution of symptoms if taken to the hospital and treated quickly. Okay, now causes of stroke. So there are different causes of stroke. We kind of break them up into two categories. We have ischemic and hemorrhagic. So with our hemorrhagic strokes, we can have, an intracerebral bleed, okay, or a subarachnoid bleed, and that's just relating to the location of the brain that the bleed is occurring. So if it's happening below the arachnoid layer, it is a subarachnoid. If it's happening within the brain itself, then it's an intracerebral. Now, ischemic strokes, we have a couple subtypes of ischemic strokes. We have a thrombotic stroke where you have an occlusion that is actually occurring at its point of origin. And we have embolic strokes where you have a piece of plaque, a blood clot that's been created, and it's floated from its point of origin downstream, and now it's caused an occlusion somewhere else. Okay, so a thrombus is an occlusion that's happening at its point of origin, where an embolic stroke is a stroke that occlusion is occurring away from where that clot originated. Okay, now ischemia, infarction, and collateral flow. So this is kind of dialing back to the ischemic penumbra. Now with this, you have this occlusion that they're showing you here. Now, as that occlusion develops, this area has no blood flow to it because of that blockage. Now, what ends up happening is these cells end up becoming ischemic, okay, which is ischemia means lack of oxygenated blood flow. And then as that ischemia gets worse, they start to die. And that's when you have that infarction. All right. Now with a collateral vessel, they'll branch off these smaller blood vessels. This is going to be, over time. The body doesn't just magically sprout these, but it's just, they over time they start to develop this, microcirculation, and then what you have is these ischemic cells that will just become silent or inactive. But if you could reperfuse that area, those cells that are silent, they may not infarcted yet, where they haven't died, they can regain function. Okay, and that's because of that collateral circulation that's been developed. Okay, now this is a quick question for you guys. Click on the statement that best describes a thrombotic stroke. Now, A, an artery in the brain ruptures, causing bleeding within the brain tissue. Okay, so we know with that one right there that we could throw that out because that is a hemorrhagic. We're talking about a bleed. Okay, so boom, get rid of that. A is wrong. All right, B, a blood clot forms in the left side of the heart and travels through the arterial system into the brain, causing an obstruction of blood flow. Okay, so we're in the right, cause here. We're in a ischemic stroke because we have a clot, we have an occlusion. We'll hold on to that one for right now. Okay, C, an artery on the surface of the brain ruptures, causing bleeding between the brain and the skull. All right, hey, we know that one's not right. We're talking about bleeding. We're in a different type of stroke in general, so get rid of that one. All right, and now D, a blood clot forms at the site of a damaged artery within the brain, causing an obstruction of blood flow. Okay, we have a clot here. So now we have our 2, B, and D, where we're like, all right, well, these are both ischemic strokes. Now, subtype of ischemic strokes, we have thrombotic and we have embolic. Well, thrombotic, this is what it's asking us about, occurs at its point of origin. Okay, so thrombotic develops where it starts. All right, so B has moved from somewhere else. So B is talking about an embolus or an embolic stroke, so that one's out. Okay, D, a blood clot forms at the site of a damaged artery, so it's occurring at its point of origin. All right, D is the correct answer for thrombotic. All right, types of stroke. So strokes caused by a blockage is referred to an ischemic stroke. Now caused by, where strokes caused by a rupture and bleeding is referred to as a hemorrhagic stroke. Now, in the field, we cannot really differentiate between a bleed and a blockage. All right, no matter how new our smartphones get, there's not an app for that yet. All right. Um, as EMS providers, the goal is to just recognize the signs and symptoms that we have a stroke. Okay, if we can recognize that they are having that stroke, then that is all we need to do. It's on us then at the hospital to like, all right, now we're going to do these additional tests and make sure that these patients get the test done, and then we can determine what route we're going to go regarding our treatment. Now, with ischemic strokes occur when the cerebral artery is blocked by a clot or foreign matter. Okay, plaque can break off, air embolus can occur. All right, they can all create a blockage. Now, a clot that develops at the site of occlusion is called a thrombus. That's where we have our thrombotic strokes. Now, with patients that have an ischemic stroke, they're going to be eligible to receive fibrinolytic therapy. Okay, and what fibrinolytic drugs do is they help break up and dissolve a clot. All right, AFib patients, atrial fibrillation is a big risk factor for patients who then can develop an ischemic stroke. Now, the reason for that is as the atria of the heart quiver, okay, that creates turbulent blood flow, and that turbulent blood flow helps create these tiny blood clots. And now when they're pumped out of the heart, they go, to the brain, and they cause that occlusion. So a lot of patients, all patients who have AFib, end up going on some kind of a anticoagulant type drug, Coumadin, warfarin, Plavix. They're on any number of your antiplatelet, anticoagulant type medications to reduce their risk of developing a stroke. Now, hemorrhagic strokes result from a rupture of a cerebral artery. A lot of times these ruptures happen because an arterial venous malformation, where you have the blood vessels that are just thin and distended and prone to rupture, especially with patients with hypertension. You can also see it with patients who have aneurysms or like a ballooning in an artery, where they then rupture and cause bleeding. Now, hypertension is, a risk factor for patients to have a hemorrhagic stroke because they're just putting so much more pressure on those cerebral vessels than they are a patient who has a normal blood pressure. Now, with signs and symptoms of a hemorrhagic stroke, ultimately for either stroke, it's going to depend on the location of the stroke. All right. Now, we know that the brain works kind of contralaterally. So if you have a left-sided stroke, you're going to see more right-sided symptoms. So a patient having a stroke on the left side of their body, stroke on the left side of their brain, you're going to see more signs and symptoms on the right side of their body. Whereas a right-sided stroke on the right side of the brain, you're going to see signs and symptoms more on the left side of their body. Now, interestingly, the area for speech occurs, on the left side of the brain for a vast majority of people. Now, with that, you guys don't need to know like super deep into the brain for this class, but you have like the Wernicke area and the Broca area of the brain. These are two separate areas in the brain. Wernicke is more receptive speech, so like being able to understand what people are telling you. If you have a stroke there, that's where like people will be talking to you, but you won't really understand at all. You think they're talking gibberish to you. You won't understand what they're saying. Whereas like a Broca area stroke, where it's happening on that side, again more on the left, that's where you're going to have issues actually creating speech, creating words, and you're going to have a condition called dysarthria, where you're not able to speak appropriately. That's where you're going to be like mumbling or slurring or jarbling of your words. All right, now other signs and symptoms that you could see are going to be nausea, vomiting, headache, decreased level of consciousness, and then uncoordinated or ataxia, where they're just not having coordinated movements. Now, again, we cannot in the field know if they're having a hemorrhagic stroke or an ischemic stroke. Now, this has been on a couple of slides, and like, well, why? Why is it so important? Like, why do I need to know? Because I've had students say, it's like, well, if my patient's having a clot in the brain, I can give, wouldn't aspirin help them? And it's like, well, yeah, aspirin would help a patient that's having a clot because it would keep that clot from getting bigger. Aspirin won't break up a clot. But we can't determine in the field what they have, and if we gave a patient aspirin that was having a hemorrhagic stroke, we would make their situation a whole heck of a lot worse. So it's important to realize, we're not going to give any medications in the field to that patient within the EMT scope of practice, simply because we can't determine what type of stroke they're having. Okay, now here's an example of a patient who's suffering paralysis on one side of the body. So obviously a previous stroke because the extremity's been splinted. Okay, to protect, you see the facial droop here on one side. So when we're seeing this, okay, it's on the right side of the body. This patient had a stroke more likely on the left side of their brain. Now, with strokes and TIAs, or transient ischemic attacks. Now, when you think of transient, you got to think of something that comes and goes. Ischemia, okay, is lack of oxygenated blood flow. So a transient ischemic attack is going to be this, onset of alteration in mental status from decreased oxygen going to the brain, or onset of stroke-like symptoms that comes on, but then goes away. This typically occurs within 1 hour. Ultimately, we're going to be treating this patient the same exact way as we would for any other patient showing signs and symptoms of a stroke. Now, another thing to take away is some of these TIAs can last, maybe 5 minutes. Okay, they can last a minute, where they have a sudden onset of symptoms and then they suddenly go away. And now they may not think anything of it. You show up and they're like, well, I feel fine. I'm good. I don't need to go to the hospital. That's not the right answer. We want those patients to still get treated at the hospital, because a lot of times, and I'm sure I'm going to have a slide coming up next that's going to say it, these are precipitating a massive stroke in the future. So we want these patients to get treated. All right, so stroke and TIAs, signs and symptoms: sudden onset of weakness, paralysis, facial droop. So we have a neurodeficit that's occurring. All right. Now, with anterior and posterior circulation strokes, all right, now very rarely do we see like a stroke that is occurring where you have signs and symptoms be present on both sides of the body. Just we have to understand that, like, if it's happening on the left side, because we have those messages that cross over, we could have like one-sided paralysis. However, if it is happening in one of the larger vessels in the brain, like like the medial, can't think of the top of my head what the name of the vessel is, but it's a large vessel that branches off to both sides. If you are having an occlusion there, what ends up happening is you can have symptoms that occur on both sides of the body. Understand, if you see that, then you should understand it's like, oh my gosh, like this is affecting a large portion of the brain because it's a larger blood vessel that has been occluded. All right, so TIAs, kind of getting back into that, same signs and symptoms as a stroke. Okay, TIAs resolve less than 5 minutes. Okay, with average being 1 minute. Now, 10 to 20% of stroke in subsequent 90 days. All right, so odds of them having a stroke again later are increased, and then half of those occur within the first 24 to 48 hours. What is that telling you? It is telling you that even though that patient may not want to be treated, that patient may refuse transport, and all that good stuff. All right. Just do everything in your power to try to convince them to go to the hospital to be evaluated. All right. They may be like, well, I feel fine now. I feel fine. No, you should still get evaluated because there is a higher risk of you having a major stroke in the future. And half of those are going to occur within the first 24 to 48 hours. All right. Now, cryptogenic stroke. Cryptogenic stroke is where you have a stroke that's occurred and it cannot be attributed to a specific cause. Now, a lot of times they think this is secondary to a fib, where it's like, all right, this patient has this heart condition where they're creating this turbulent blood flow, creates an embolus that causes the occlusion. Okay. Now, this is just thought to be secondary, but ultimately they have a stroke that occurs and they can't identify the root cause of it. All right, so with our scene size up, we need to determine the nature of the problem. Okay, so try to figure out what's going on. This, you're going to have to look a lot at the signs and symptoms that you're seeing because some of these patients may not be able to articulate what it is that they are feeling or what it is that they're going through. So you really have to look at what you're seeing objectively with that patient. Okay, take into account the scene as you're walking in. Okay, is it 3 o'clock in the afternoon and the patient's still in bed, in their pajamas? Okay, that could be giving you an idea on kind of the onset of symptoms or this patient's, last known well time. Most people, unless they work nights, are typically up and out of bed by 3 o'clock in the afternoon. So you have to look at that and be like, all right, like, well, if I'm having a hard time determining, it's like, well, the patient's still in their pajamas. Possibility the stroke happened, way, way earlier, increased because of their attire. Okay, look at what's going on around the patient. Are there, trash cans by the bed? Do you see, like tissue at the nightstand? Things that would indicate that maybe the patient's had some kind of an illness before, that could be uh, increasing this patient risks. Look at the medications that the patient that are around. Do they have medication that's common to patients with, atrial fibrillation? So those are all things to consider. And that's a way you could size up the scene to help determine what's going on with the patient, especially when you don't have people to just feed you that information, like friends or family or bystanders. Now, primary assessment, like we talked about, it is very, very important to protect the patient's airway. With alteration in mental status, the patient can lose control of like the tongue, like so that muscle just doesn't have any stimulus going to it, and that tongue can cause an airway occlusion. So we may need to make sure that that patient's airway is open. Okay, secretions can be present, so make sure you suction out any secretions. Sometimes patients can have this onset of a stroke and fall, bite their tongue, and have bleeding, so you need to be able to suction. Position the patient. All right, so if that patient is having weakness to one side of the body, make sure you're positioning them in a way that protects that extremity so we don't have any extra trauma. Now, if we're positioning the patient for airway protection, if I don't have any spine injuries, patient has snoring, I would put them in a lateral recumbent position. All right. Other times, if my patient's able to, for the most part, sustain an airway, put them in like a Fowler's position where they're sitting up. Okay, but you really have to size up the patient and see what they can tolerate. Now, airway adjuncts, of course, as clinically indicated. So if I have a patient that's snoring and positioning isn't working, I can use an OPA if they don't have a gag reflex, or an NPA to help position the adjunct between the tongue and the pharynx to keep that pharynx open so we can get good airflow. Now, assess for inadequate breathing and then provide positive pressure ventilations as clinically indicated. So if there's inadequate breathing, we need to breathe for the patient. Now, if the patient is breathing adequately, then we'll apply some supplemental oxygen just to keep that SpO2 above 94. This is another case, just like cardiac, where we want to be very careful with oxygenating our patients. So that's where we're going to start low and just give them enough oxygen to keep their O2 sats above 94%. Now, with our secondary assessment, that's where we're looking at findings that are suspicious for stroke. So that's where we're going to use our, the FAST acronym. Also, as part of our Cincinnati Pre-Hospital Stroke Scale or the LA Stroke Scale, we're going to be using some kind of an assessment tool to look for stroke. Now, with these patients, we look for that onset of weakness, the face or extremities, difficulty speaking or seeing. I've had a stroke patient walk into a clinic, and the only complaint they had was like on one side of their visual field was kind of like spotty, and they had like dots, and they had a horrible headache. But they walked into this facility, and we ended up getting them to the hospital. Come to find out they're having a stroke just in the area of their brain that affects vision. So again, be able to recognize some of these smaller symptoms. Now, problems walking or loss of balance or coordination. Another patient that I had, the whole reason they called 911, that it was a husband and wife. They were at the grocery store, and the husband noticed the wife walking and drifting to one side when she would walk. So she would walk, instead of walking in a straight line, she would drift to the right. And it concerned them enough to call 911. Come to find out she had a brain tumor, okay, that was affecting her gait or her ability to stay, in a straight line. Now, that would have never been found if they would have just thought, oh, she's just, maybe favoring one leg or whatever, but it was this sudden onset of this, and it was like, whoa, let's get you checked out. Come to find out it was a brain tumor that was affecting brain function. Okay, sudden onset of a severe headache. It could be another symptom that you get. Now, with assessing, two of the very common stroke scales that we have, and we're going to talk about them later, is going to be the Cincinnati Pre-Hospital Stroke Scale and the Los Angeles Pre-Hospital Stroke Screen. Now, with the Cincinnati, of course, we're looking at facial droop, we look for arm drift, and then we check speech. So we'll have the patient say back a common phrase like, you can't teach an old dog new tricks, or it's always sunny in San Diego, something. And you're looking to see, one, do they understand what you're saying? And then two, can they articulate it back to you appropriately? All right, that's Cincinnati Pre-Hospital Stroke Scale. Is very, very simple and easy to use. Now, with the Los Angeles Pre-Hospital Stroke Screen, we're still looking at facial droop, arm drift. We're checking grip strength, but we're also looking at some of the more underlying risk factors. Are they an older patient? Are they greater than 45 years of age? Do they have any history of seizure, that we need to be aware of, that could be presenting very similar to a stroke? Okay. How long have these symptoms been occurring? Is it less than or greater than 24 hours? Okay. Is the patient, bedbound, where they're high risk for developing, clots? Okay. What's the sugar level? Now, sugar level is something that we're going to want on every stroke patient as well, because hypoglycemia can present itself as stroke-like symptoms. So as as a nurse in the emergency room, we have a patient coming in with stroke-like symptoms. Last note all the time is something I want to know, but I also want to know what their sugar level is. Like, what's that blood sugar? Because a hypoglycemic patient, it's very simple, to counter their sugar. We can give them, oral glucose, or we can give them, dextrose through an IV to help get those sugar levels up if they are hypoglycemic. It's so simple to fix that. So, like, sugar levels are going to be something that we want. The Los Angeles Pre-Hospital Stroke Screen does incorporate those extra assessment tools. Now, we do have two types of stroke centers. We have primary stroke centers, and we have comprehensive stroke centers. Primary stroke centers primarily deal with ischemic strokes, as they can give, fibrinolytic therapy or thrombotics to help bust up a clot and to reperfuse the area that's been included by, a blood clot. Now, comprehensive stroke centers, on the other hand, they can do fibrinolytic therapy, but they can also do vascular surgery to repair, vessels that have been ruptured with hemorrhagic strokes. Okay, so just comprehensive stroke center, a little bit more in depth, a little bit more capability to manage, both types of strokes, whereas your primary stroke centers are only going to be along the lines of, fibrinolytic therapy for ischemic strokes. All right, so this talks about the Cincinnati pre-hospital stroke scale, facial droop, arm drift, abnormal speech. Now, with the facial droop, uh, a lot of times patients don't want to smile. They may not have teeth. They may have bad teeth. And I'll tell you, even in the hospital, I've had patients who like don't want to smile because they don't have any teeth or they have bad dental hygiene. So one thing that I look for instead of like, hey, smile for me, and they're like, no way. I've literally had patients tell me no. More like, hey, can you raise your cheeks for me? Raise your cheeks, or just like something else besides smile, because a lot of times they won't want to show your teeth. So you might have to rephrase some things. Now with arm drift, one thing you guys can do is have the patient close their eyes, put their arm straight out in front of them, and you're going to have them hold them up for 10 seconds. Okay, now if you do have one arm drifting down, just before you have the patient open their eyes again, take their hands, put them back together, and set them back down in their lap. And now tell the patient to open their eyes. Because imagine the kind of panic you would cause if in their mind they're like, I'm holding both my arms up, and then they open their eyes and one arm's completely flattened down the other side. Now, with the abnormal speech, you are looking for them to repeat the phrase back to you. But look for like them slurring their words. Look for them to be mixing words up or repeating words or stuttering, any kind of speech abnormality. Okay, so like look at that. You're not just looking. You can't teach an old dog new tricks, and they're like, you can't teach an old dog new tricks. You can't teach an old dog new tricks, or dogs tricks tricks dogs tricks new tricks dogs new tricks. Like you want to really look for like any abnormality in their speech. Okay, that should be raising red flags for you. All right, we talked about the LA pre-hospital stroke screen a little bit already, but that's where we're taking into account some other factors like seizure history, sugar levels, age, are they bedridden? So we're really looking at some of these other factors that increase the chance of stroke, or looking at other things that could present as a stroke to kind of rule them out. Now, secondary assessment. Obtain a history and perform your physical exam. So with your history, get your sample, allergies, medications, past history, last oral intake, and events leading up to. All right. Look for some of the risk factors in that: the history of hypertension, history of atrial fibrillation, history of high cholesterol. All those things play a role. The physical exam, do a good neurological assessment of the patient. Assess their pupils. Do a stroke scale, facial droop, arm drift, speech. Look at that. Check grip strength. Check upper and lower extremities for motor sensory function. And then get a baseline set of vitals on that patient so you can identify trends. Is the patient getting better or getting worse? Now, always, always, always be very careful with oxygen. Okay, so we do not want to create free radicals by over oxygenating the patient, in a sense, oxidizing them. So we do not want to over oxygenate the patient. We just give enough oxygen to titrate SpO2 greater than 94%. Okay, so here's an example of facial symmetry. All right, whereas one patient you have, good cheek res on both sides. In the hospital, we have them, close their eyes, open their eyes. We have them raise their eyebrows up, like with the facial nerve, like the trigeminal nerve. You have three branches of that nerve that go to lower, middle, and upper. So upper face. So we're actually like, look, okay, can you raise your eyebrows? Can you close your eyes? Can you smile? We're checking like all levels of those nerves. Okay, but look at this patient here. You see facial droop on one side. Still able to raise both eyebrows up here, but just down low we have that drooping. All right, here's an example of arm drift. So what we'll do, of course, like I was saying, hold it up for 10 seconds. Once we're done with this assessment, I'm not going to have her just open her eyes and look at like, okay, look where you're at now. It's like you put those arms together, put them back down in her lap, and then document your findings. Alright, so this is kind of a different layout of the different signs and symptoms you can see. So again, we're looking for those neurological deficits with signs and symptoms of a stroke. Hemiparesis, alright, affecting one side of the body. We're looking at alteration in mental status, looking at slurred speech, looking at their pupils, are they unequal? Looking at their gaze, are they like leaning off to like their head off to one side and their eyes just staring off into one area because like the ocular motor nerve's been affected. So just really look in and assess those patients. All right, a lot of different signs and symptoms that we can have. We've talked about a lot of them already. So emergency medical care is going to be maintaining the patient's airway. All right, with alteration in mental status, guys, big issue here is going to be the patient uh, not being able to secure their own airway. All right, so make sure you maintain that airway for them. Assist ventilations as needed. Maintain adequate oxygenation. Remember, just enough to keep SpO2 above 94, and then position that patient. Okay, left lateral recumbent position can be great in the fact that it will keep that airway open. If the patient can tolerate it, sit the patient up in like a Fowler's position. So protect that extremity too, because we don't want the weakened or paralyzed extremity to become injured with trauma because we're not protecting it. All right, so here we go. We got lateral recumbent position here. Okay, we got a Fowler's position if the patient can tolerate it. Okay, for our care, check blood sugar levels, protect the paralyzed extremity, and then rapid transport, especially if we have that new or sudden onset of symptoms. Remember, 2 hours to get the patient to the hospital. Okay, they have 3 hours, once they get to us, with 3 hours to administer appropriate medications, all right, the fibrinolytic therapy. So, very important. 2 hours from the onset of symptoms to get them to the hospital, and then we then have 3 hours from onset of symptoms to deliver medication. Now, there is some, leeway there. Your book talks about up to 4 hours, but the main window is 2 for delivery to the hospital, 3 to deliver the medicine. Reassess your vital signs every 5 minutes. These are going to be critical patients. All right, now with headache. Headache, of course, it can be a condition. So migraines is a condition in and of itself. All right, but it can also be a symptom of an underlying issue. Okay, headache could be a brain tumor. Headache can be a stroke. Headache can be an aura that a patient gets prior to having a seizure. Headache could be from hypoglycemia. All right, so we never want to just dismiss, oh, the patient has a headache, it's no big deal. We want to do an assessment still, dive into that symptom and be like, okay, is there any underlying cause of that? All right. Now, we have different types of headaches. Okay, we have vascular headaches, which are thought to be more from like the vessels in the brain that constrict and relax, which trigger a headache. Now, hypertension can definitely cause headaches. A lot of people have migraine headaches now from those blood vessels spasming in the brain. Now, with migraines, a lot of those patients have like extreme photo sensitivity, where they're sensitive to light, very sensitive to sound. They can get blind spots in their visual fields, or they could have issues even with like double vision, up to and including like hallucinations. Okay, so migraines can be very serious and they can be very debilitating. Okay, so we never want to just dismiss a migraine headache. If we have a patient with migraines and they do have photosensitivity, we'll do things like dim the lights in the patient compartment of the ambulance. We'll do things like limit sounds, okay, to try to help the patient with their symptoms. You still got to do an assessment. Like you kind of like, look, I have to ask you these questions, but you're just trying to limit those issues. Now, cluster headaches, okay, also thought to be vascular. However, they happen repeatedly, and they typically tend to happen on one side of the head. All right, so cluster headaches also considered like more of a vascular type headache, but they just happen like over and over again, and they typically will affect one side of the head. Now, tension headaches Tension headaches are thought to be more from muscles. All right, so you have somebody who is stressed out at work. Those shoulder muscles are very tense. They're furrowing their brow, and those muscles are very tense. It could causes like a band-like type headache that goes completely around the head, almost like they're wearing a really, really tight hat. Uh, those are more muscular in nature and have a band-like type pain. Then, of course, you have your organic headaches. Now, those are going to be considered more from like conditions. All right. So, with organic headaches, that's where the patient has, an infection, meningitis, inflammation of the meninges. They have a high fever. Maybe they are having a stroke, and that's why they have a headache. Maybe they have bleeding, and that's why they have a headache. Okay, those are going to be our organic traction or inflammatory type headaches. Now, with assessing a patient with a headache, all right, if a patient has a headache and they have any of these symptoms, all right, we are going to consider that a very serious symptom, a headache. All right, so if they have any altered mental status, if they have a neurological deficit, if they have a behavioral change. Now, the prefrontal cortex, frontal lobe of their brain controls things like emotion, okay, and ability to rationalize. So if they are having a behavioral change where they are acting outside of their baseline, hey, normally they're very calm, cool, and collected. Now they're like emotionally distraught and they have a headache and they are not uh, acting, in a way that family is used to. That's considered a behavioral change. That should be a very serious finding. Okay, and of course, if they're showing, they're having seizure activity, that should also be a very serious finding. Now, also things that we're looking for, patients who have this severe headache and it's the first time that this has ever occurred and it's a very acute onset. Patient that's having increased pain when they cough, sneeze, or bend over, or have a fever or a stiff neck. Very indicative of meningitis. Meningitis is very contagious. You guys should be protecting yourselves, mask, all that good stuff. Like I think we're all wearing masks now for everything. But that is indicative of meningitis. It's very contagious. Protect yourself. It's also very dangerous for the patient if not treated. And then change in the quality of a chronic headache. Like if a patient has um, migraines normally, all right, and they're like, this is a migraine, but it's like 1,000 times worse. And now they're kind of slurring their words. Like, okay, well, they have chronic migraines that they deal with. However, the presentation of this is different. So there might be something different going on within the patient. So they should be evaluated and get checked out. Now, our emergency care, again, very similar to everything that we've talked about. Maintain your ABCs, maintain adequate oxygenation, place the patient in a position of comfort. A lot of times I've had patients that just want to pull the blanket up over their head so they could shield their eyes, so maybe dim the patient compartment and create a comfortable environment for the patient. Be prepared for seizures, okay, and then transport the patient to the hospital. So, in conclusion, okay, causes of altered mental status can be structural, like brain tumors, okay, like stroke, like bleeding from the brain, but it could also be metabolic or toxic, hypoxia, hyperglycemia, issue with kidney or liver function. You will need to know your different types of stroke. So you will need to know that we have ischemic strokes and we have hemorrhagic strokes. Remember ischemic, okay, remember our subtypes too. Ischemic strokes, we have thrombotic and we have embolic strokes. Okay, hemorrhagic strokes, okay, it's a bleed, it all depends on where that bleed's occurring. We have intracerebral bleeds, okay, and we have subarachnoid bleeds. All right. Now, time, again, very important. When was the last known well time and getting that patient to the facility if they are within that window to receive appropriate care? Okay. Use a validated stroke scale to assess the patient. Again, very common ones, Cincinnati Pre-Hospital Stroke Scale and LA Pre-Hospital Stroke Screen. All right, are acceptable stroke scales for you to use. Headache may be a condition in and of itself or a symptom of an underlying condition. Never dismiss a headache, okay? Because it could be something that you pick up where you may dismiss it and the patient was like, well, I don't want to go to the hospital now. And in all actuality, they have something very serious that's occurring. And because of how you approached it, you made the patient feel like they're wasting your time calling 911 for it. Always treat it as something serious. Okay, don't ever dismiss the patient's concerns. All right, and that concludes this class. Thank you for listening.